Good morning and welcome, everyone. The maternal mortality crisis in the United States has been well documented. US women have the highest rate of maternal death among high-income countries. And Black women are nearly 3 times more likely to die from pregnancy. And for Indigenous women, the numbers are 2 times. In 2020, there were 24 maternal deaths per 100,000 live births, more than 3 times the rate of the 10 other comparable high-income countries in a recent Commonwealth Fund survey. In addition, as many as 60,000 women in the US experience maternal morbidity, unexpected outcomes during labor and delivery resulting in short and long-term effects on their health and well-being. Many of these physical and mental effects are severe and long-lasting. It's been more than 4 years since Serena Williams brought this issue to the public consciousness so powerfully with her harrowing story of the birth of her first child. This was a grim reminder that neither resources or fame offer full protection from the risk of giving birth while Black. The urgency of this crisis is reinforced by the fact that maternal death and morbidity and the associated disparities in outcomes may be a bellwether for the larger US failures with respect to women's health and healthcare. Today, I am joined by 3 of the leaders in the effort to solve this crisis. Kim Keck, President and CEO of the Blue Cross Blue Shield Association. Kim has had a long career in leadership and innovation in the private insurance industry. Dora Hughes, Chief Medical Officer of the CMS Innovation Center at the Centers for Medicare and Medicaid Services. Dora has extensive experience in government and private sector with a strong focus on issues related to equity. And to my far left, Stacey Stewart, President and CEO of the March of Dimes. Stacey is a powerful nonprofit leader, and as the first Black president of the venerable March of Dimes, she has elevated issues of health equity as she advocates for better outcomes for maternal and child health and for a better future for all moms and infants. I'm delighted to have the opportunity to be with you all today to address the critical questions around how we got here and how we can eliminate unacceptable disparities. I should have introduced myself, I think, early. I'm Kathy Regan. I'm the Chief Operating Officer of the Commonwealth Fund. And we've spent quite a bit of effort and time looking at these issues ourselves at the fund. So let me start with an opening question and begin with you, Kim. How are you and your organization addressing the challenges and opportunities related to addressing maternal health disparities?
Yeah. First of all, thank you, Kathy, for moderating. Thank you for Dora. Thank you for Stacey. Such an important conversation that we want to have today. I think about, in some respects, Kathy, reframing sort of why are we doing this work. And you clearly and articulately and vividly painted the picture, right? This is a crisis right in front of us and has been for some period of time. You know, for me personally, I think this came home, if you will, about, gosh, almost a year ago now. A friend of mine called me one day. My friend's daughter was having her 3rd child, and that daughter and her husband and other 2 children were coming to visit my friend in Rhode Island. And my friend called me and said, hey, Leah's coming to visit. She's in her 3rd trimester. She could go into birth early and into labor rather early. And so can you help me out? I was like, of course. And she said, I need a safe place for Leah to give birth. And I thought, that's a funny question. Nobody ever asked me for a safe place to have a baby. And then I paused for, about a nanosecond and was like, oh, Elise and Leah are Black. And that's on their minds, right? Because just the fact that her skin color is what it is means she is more likely to die in childbirth. So I think about Leah, right? So Leah, like Serena Williams, women who have means. Leah happened to go to Dartmouth undergrad, has a PhD from Princeton, was a professor at Harvard, and had resources to know what questions to ask. So I think about, the moms among the 87 million Medicaid population, right, who might not have the resources, who might not know the questions to ask, who might not know how to navigate this challenging time in their lives. So in any case, we, given the picture that you painted, given our own personal experiences, said, look, we want to lean in. I came to the association 18 months ago and I said, one of the things I care deeply about is creating a better system of health. Not a better healthcare system, but a better system of health. And a better system of health is one that's equitable for all. We also specifically said, okay, that's our sort of umbrella goal, but embedded in that is a very specific goal on maternal health and reducing disparities in maternal health by 50% in 5 years, which is a bold goal and one we cannot do on our own. So we love the thought leadership, and more than the thought leadership, the action that's in this virtual room and on this stage. I'll quickly share with you, we quickly put together a frame, not quickly, but I'll quickly share the framework we put together that had key components of any sort of campaign, if you will, to cover multifaceted solutions to these sets of issues. So first and foremost, policy and advocacy is part of what we're doing and how we're approaching this issue. Certainly partnerships, particularly with providers, but with other entities, community-based solutions, getting at the root causes, the social determinants as we call them in healthcare, and then importantly, data. And so the combination of those categories, if you will, have many different approaches embedded in them that I'm happy to speak to, but that's sort of the overall framework. And we have some great partners here to do this work to drive some solutions forward.
Great. Well, we'll talk a little bit more about those models in a minute, but let me ask the same question of Dora.
Thank you, and thank you for inviting me to join this event today. Maternity health is a top priority, certainly, as we all know, for this administration, for our administrator, Chiquita Brooks-LaSure, who is here today, as well as for the Innovation Center. For those of you that are less familiar with the Innovation Center, we were created as part of the Affordable Care Act in 2010. We were charged with implementing large-scale models, as we call them, some equivalent of research demonstrations, but what we call models that can improve quality of care and reduce costs. We have high hopes that our models would achieve both, but at least quality or costs have to be addressed through our models. We have launched about 50 models to date since inception. We have about 28 that are going on right now. And they focus on, in many cases, certain conditions, whether that be maternity care or end-stage renal disease or diabetes or behavioral health. We focus on certain provider types, whether that be OB-GYN and other specialists or primary care, behavioral health providers. We focus in certain areas, and that's certainly critically important in rural areas and urban areas, and we focus across Medicare as well as Medicaid, as well as our other Medicare Advantage dues as part of the Medicare. There's a lot of findings. I would say our first flagship model that focused on maternity care was about 5 years ago. It's since concluded, and we have some learnings today that I can share as part of this other panel. But I would also be remiss if I did not mention very briefly the efforts by my other colleagues at CMS. Certainly, and as an example, for our Medicaid Center, they are quite focused on expanding postpartum coverage because we know that a number of adverse events happen after the birth, and in many states having Medicaid coverage terminated 60 days post-birth was impairing the health of the moms. As another example, our colleagues in the Centers for Clinical Standards and Quality, CCSQ, are increasingly looking at the quality of care, quality measures in hospitals and other facilities where women give birth. And so I think it is a holistic look across CMS, and I look forward to diving a little bit deeper as part of this panel discussion.
Great. Thank you, Dora. Stacy, how about the March of Dimes?
So first of all, thank you, Kim and Blue Cross Blue Shield, for inviting me to be a part of this conversation. It is really an important conversation, and we're really proud to be partners with Blue Cross Blue Shield on a lot of this work, especially around maternal and infant health equity. A lot of folks know the March of Dimes. You probably know us more from our polio days. That's how most people know. Or most people know us also because they tell me all the time, I went around and filled up a card to raise money for the March of Dimes when I was growing up. If that's you, thank you. We appreciate you. Today, though, the March Times is one of the leading, if not the leading, nonprofit organization fighting for the health of moms and babies. And just a quick little note on that. I started at the March Times 5 years ago when our primary focus was on premature birth, ending preventable premature birth, and it still is a huge part of our strategy. Over the past 5 years, it's been really, really incredible to look at the data and really understand, though, that honestly, if we want to have healthier babies, we need to have healthier moms. And the two very much go together. So we have framed our entire strategy at the March Times around both healthy moms and healthy babies. And when you look at the issues we've been talking about around maternal health, it's hard to ignore the fact that today we are considered the most dangerous developed nation in the world in which to give birth. So when you look at other highly industrialized countries, wealthy nations, our outcomes around maternal health, maternal mortality and maternal morbidity, women that die as a result of pregnancy and childbirth or come close to death, is the worst as compared to every other highly industrialized country in the world. We spend as much money, if not more money, on healthcare and get the worst outcomes. And we know that across the whole spectrum of healthcare, but absolutely is true around healthy moms and healthy babies. And then further, when you look at who's really affected the most, we cannot ignore the fact that, as was mentioned, Black and brown women are bearing a disproportionate burden of the challenge, where Black women today die at a rate of 3 to 4 times that of white women. If a woman's over 30 years old, it's more like 4 or 5. A Black woman dies at a rate of 4 or 5 times that compared to white women. Indigenous women are facing enormous challenges. And on the infant side, I'll just tell you, it's not much better. We've got incredible disparities as it relates to infant health as well. And so the question is, why is this going on? And that's certainly the work of the March Times and working with partners like insurers, like Blue Cross Blue Shield, like CMS, and so many others. You know, there are a lot of fundamental, there's no one silver bullet solution to this. Mostly what we know about our health is that our health is not really determined in what happens in the doctor's office, although it's really important to be able to go to a doctor that you can afford, that is close to you. But what we know about health in general, and this is true for maternal health, about 80% of our health is determined by how we live. So when we are living in communities that are unsafe, when we're living in places where we don't have access to safe, decent, affordable housing, where we don't have access to good nutrition, where we don't have access to safe neighborhoods, where we are living in conditions that are entirely, incredibly stressful, that is going to have an impact on our overall health. And that's what we're seeing in a lot of these cases around maternal health. You know, some of the leading causes of death for women who die as a result of pregnancy and childbirth are heart-related issues. They're chronic health conditions, sometimes happening before the woman is even pregnant, may get exacerbated through pregnancy, and in the postpartum phase, we're still seeing tremendous challenges. About 1/3 of all the deaths happen during pregnancy. About 1/3 happen right around the time of childbirth, so right within a week of childbirth or at the time of childbirth. And then from 1 week out to 1 year, another 1/3 happen. So this is really, there are a bunch of systemic issues I'm sure we'll get into. There are definite failures in the system, but there are also some just basic issues that we need to address with respect to the kinds of ways in which women are able to manage their health, and especially doing so before they're pregnant, so that if they run into challenges during pregnancy, they can kind of minimize that, they know how to access the kind of care, they're empowered to make better choices, and that they have tools available to them to manage their own health. The last thing I'll just say is that we've got to figure out a different way to get these kinds of resources and supports to women of color, to women in rural areas, to low-income women, because that's where we're seeing the most vulnerability, and that certainly is at the core of what we're doing at the March of Dimes.
Yeah. That's a great segue into the next question. I want to invite you to dig deeper into a specific program or policy or model that you think is really making a difference, because we want to focus on solutions. Dora, let me ask you to go first, and then we'll move on to Kim and Stacy.
Sure. As I mentioned, we had one I would consider a flagship maternity care model, the Strong Start. And in that model, it really considered more innovative, certainly 5+ years ago when it was launched. But one track focused on the midwifery birth center model of care, a second track focused on group prenatal visits, and the third track focusing on the more traditional hospital-based maternity, almost medical home type model. And I think many were surprised that the birth center midwifery model was the most effective by far. And we had over 30 states were participating in the model, over like 45,000 women across all different types of communities, areas. It had overrepresentation of women of color, Medicaid strongly participating. And so then knowing that, it was how do we translate that findings in a model to what is practiced uniformly and systematically? How do we make that to be more of the standards, or even understanding what are the components that should be replicated? We know there's quite more focus, obviously, with the midwifery, the birth center model on relationships, on the patient experience, taking more time, being more holistic in addressing the social needs and behavioral health needs, all of that. And so that, in some ways, has really informed our thinking in terms of how we would like to move forward. We have a second model that we launched last year. This one is focusing on moms with opioid use disorder and in rural areas. And so really trying to, how do we take this other highly vulnerable group of women and try to keep them in treatment during pregnancy and beyond. And we also, to Stacy's point, we have, as part of our pediatric focus model, integrating care for kids, is focusing, one of the participants were allowed to focus on maternity care, and really with focusing on like the pregnant mom, the family, and the children, understanding that, again, trying to draw these artificial lines is to the detriment of health for both the moms and the babies. But there are obviously a number of barriers in terms of how, for CMS, how we cover midwives, how do we cover the institutions. There's a lot of federal issues, and then certainly in the state and local areas in terms of licensing and other considerations there. So for us, even as we increasingly have the research, the evidence, is how do we translate that so it's become more the standard or more the norm and available to all moms, regardless of where they may be.
I'm smiling only because so much of what you've both said so far, even in a few minutes, I'm like, yes, and, yes, and, yes, and. So yes, and. One of the things I'd say in terms of where we're starting and some of the things that we're doing, first and foremost on the advocacy front, and you touched a little bit about this, Dora, sort of in the postpartum, right? So we are big supporters at Blue Cross Blue Shield for the Momnibus package of bills. Embedded in Momnibus is many things, one of which is extending postpartum coverage 12 months past delivery in Medicaid. But we're actually heartened to see through, I guess it's the American Rescue Package, I think the option, right? I forget the name of the option, but I'll just call it the option for states to extend. And I think 19 states have already extended postpartum coverage in Medicaid for a year. And I think there's almost as many underway, at least considering. I'm hopeful that that considering really means underway. So look, first and foremost, we're advocates. We're not just advocates on the issue of postpartum. My colleagues often talk about postpartum care or postpartum period as the sort of fourth trimester. And we know during that trimester some of the things that happen. 1 in 9, I think, during that period suffer depression. And we don't have, maybe you do, but I don't think we actually have good data of how many Black women are suffering from postpartum depression, because I actually think so many go undiagnosed. So a couple examples of things we're doing to address that issue, just quickly, because I think some of it is already articulated here, but one of the things we're doing at one of our Blue plans, Blue Cross Blue Shield in New Jersey, called Horizon, is implementing a very specific training program, incenting physicians who are serving primarily Black moms and saying, look, we have to do screening differently. It actually doesn't even sound all that different, but it's maybe doing the same things and just doing them differently. Maybe asking different questions to Black moms, listening for answers that are different, or maybe understanding there may not be a level of trust from the person who's asking the questions, looking for physical signs of depression and the like. So certainly a whole host of incenting and providing that funding for the clinicians to do screenings postpartum. And then I would just amplify what you said a few moments ago, Stacy. The other thing I would say that we're really leaned in on and 20 states across the country, partnering with the March of Dimes. We have 1.7 million providers, traditional providers, which I'll come to the maybe non-traditional part soon, but that are in sort of our network, right? We provide insurance and we have a network of physicians and hospitals. And right now in our 20 states, we're touching tens of thousands of moms from our partnership with March of Dimes, and there's a huge opportunity to touch so many more. So those would be sort of two quick programs I'd give. I'm sure there are more, but let me pause there.
Thank you.
Yeah, I would just add to that, if I could, and Kim did a great job covering a lot of policy things, because we're very much in partnership. A lot of us are advocating deeply around Momnibus and a lot of other bills that are trying to make their way through Congress. So I won't touch on that, because I check on all of that. But I'll mention one other thing, which is, and it sort of goes back to the Serena example, and then I'll tell you a very quick little story about Charles Johnson, who some of you may have heard, and his wife Kira, who died at a hospital in LA, just had what was to be an ordinary C-section. They went in the hospital. After recovery, Kira developed blood in her catheter. Charles was sitting at a bedside, noticed it, tried to get the attention of the nurses. The nurses basically told him that she was not a priority. They actually said that to him. After advocating for hours for a CAT scan and for other things to happen, Kira's vitals just dropped dramatically. She was rushed back into ER. She had 3 liters of blood in her abdomen and coded on the spot. I'm saying that to say that, we're talking very high level about what these issues are, right? And that, these are, there are policy issues and there are, all kinds of medical things that need to be addressed at a systems level. But what we're talking about are actual women and actual families where the mom dies or comes close to death, and the children are left without a mom to raise them. And that this happens too often for many Black and brown women. And in this case with Charles, and is similarly the case with Serena, where women of color, irrespective of their resources, often feel ignored and unheard in the treatment that they are hoping to receive from their healthcare provider. What the March Dimes has done is we started a few years ago an implicit bias training program, and we've been working very closely with Blue Cross Blue Shield and others on this. We've trained 35,000 healthcare professionals to help them begin the journey of acknowledging and understanding if they have implicit bias that could stand in the way of delivering high quality care to any woman, irrespective of her race or ethnicity. We've now just started a student bundle to get that training to medical students and other healthcare professionals in their training, so that they get trained in this way and understand as they move into being a practicing physician or nurse, how they need to think about their own selves and their own ways of thinking, so that that doesn't interfere with, again, high quality care delivered to any woman. We have heard many women of color express to many that they have felt that there have been racist interactions with their healthcare providers, not just with physicians or nurses, sometimes with the front desk receptionist. When I show my Medicaid card and someone judges me because I'm on Medicaid. These are the real stories that happen that impact how care gets delivered to women who look like me. So part of what we're trying to do is to, we're not going to cure someone's implicit bias for their training. I don't want anybody to think that. But you have to start somewhere. You have to first recognize there's a problem. It's like a lot of other things in our life. If you don't recognize that there's a problem, you can't solve it. But once it's recognized, you can begin a journey to actually begin to rectify it and improve, hopefully, outcomes over time.
Great, thank you. I know we don't have as much time as we need for this important topic. So Kim, you've talked about data. You've touched on data as well, Dora, and we've also talked about expanding the workforce and opportunities for non-traditional actors in the workforce. Let me invite you to just touch on one of those issues in the interest of time, so we can open it up to the audience and talk about what's needed there and where the opportunity is. Sure. I'll start with you, Kim.
Okay. And gee, I want to talk about both, but I'll talk about it's a tough choice, Kathy. I guess I'd start with workforce, right? Because I think there's a nuance when we talk about workforce, and you know, we read the headlines, right? We read the headlines that 1.7 million people have left the healthcare workforce in 2021 or 2022, this year alone, and the numbers are staggering. And I sometimes think we sort of have to look at the story beneath that story, because I'm not sure I'm as focused on that number as I am thinking about what's beneath it and the roles, the real roles we need in healthcare, and in this issue more specifically as it relates to maternal health, right? So we were talking about this recently, we were joking, we have to build back our workforce, but we have to build it back better. And you might catch the subtle reference. But in any case, my point is this. We are using doulas in Blue Cross Blue Shield of Minnesota as one example. In that Blue Cross plan, that plan put a program together to both fund scholarships for doulas, particularly people of color who are serving diverse populations. That plan also increased reimbursement by 60% for non-birthing visits. And I would also mention perhaps even our program in Vermont, where we had midwifery, same thing, sort of the foundation for the maternal health delivery system. And then the plan I came from in Rhode Island, where one of the things Blue Cross Blue Shield of Rhode Island did was say, look, we're going to pay pediatricians to add care coordinators or clinical social workers, depending on what the pediatricians' need were, to say, look, if a mom is able to bring the baby in to see the pediatrician, which is a feat in and of itself for some women, while we're there and the pediatrician is actually seeing the mom, let's actually have the the screening for postpartum depression at the same time of the mom, so we can, have that integration happen a little bit more effectively. So finding those right roles, I think, are really an important component as we think about the workforce.
Great. Dora, do you want to talk about data?
Okay. I was like, shoot, I wanted to talk about doulas too. Okay. I will.
Doulas are always more interesting than data.
I will change up the focus. So another top priority for us certainly is on racial and ethnic data collection. I think we've talked quite a bit about the disparities that we've seen. For us, it was very interesting, even for our model, when we looked at centering versus the group visits versus the returning, there were some clear patterns by race and ethnicity, and we were statistically powered to identify these differences. And it showed that although, for example, the birth centers did the best in terms of the lowest rates of preterm birth, the lowest rates of low-income babies, there were still occasionally you would see some differences. For example, African-American moms they did do better than others in the group, in the maternity medical home models that were hospital-based. And so really being able to tease out that even as we look very broadly at the outcomes of these models and where the care is being delivered the best, but then looking at the specific patterns by race, ethnicity, and other demographics. And so that is just one example of how we're looking at data. I would say very briefly, we released our health equity strategy for the CMS Innovation Center. Also at CMS released its equity framework. Racial and ethnic and other demographic data collection is a top priority across each. We are increasingly moving from encouraging to requiring, moving forward so we can have the gold standard patient-reported data. But even still, we're not waiting until we have the perfect data. We're also taking a very pragmatic approach. We are, saying in some contexts, we're looking at what we can beg, steal, and borrow, but that doesn't always resonate with my colleagues at CMS. But we are looking internally at thinking here and now. This is the data that we have. Medicare has some demographic data, Medicaid less so. So we are also looking at what are some appropriate proxies in some cases, such as dual status. We're also looking at imputing data. Some of the algorithms can get pretty darn close if you look at it at population level. Those are the two unparalleled tracks. What can we do with the here and now? what do we need to build towards the future? I'm going to avoid any political jokes that would get me in trouble. And we are increasingly relying very much on our partners. I had mentioned earlier that, as one example, we had Blue Cross Blue Shield Massachusetts come in and share their experience with racial and ethnic data collection. That is directly helping to inform what we are doing in the Innovation Center. And I think even though it's one plan, there are other plans too that are sharing their experiences as they're doing more in this health equity space. And so that in a nutshell, I would sum it up our data strategy.
I might give Kim a chance to just comment on data in the private insurance industry, and what you're seeing.
Yeah, I think we've talked about this a little bit. Our data is, and the self-reported is not high. I think across all the Blue Cross Blue Shield plans in the country, we serve 115 million people, and I think, we have ranges of data on REL from in the 30-ish% range of our total population, and that's just sort of the tying it to their sort of membership, if you will, in a Blue Cross Blue Shield plan. It's not the longitudinal how they seek care, where they seek care, what the outcomes of the care is or are. So we absolutely are all for standards and love your perspective on, just having a single standard, particularly in the REL data. I'm a big believer you cannot manage what you cannot measure, and we're doing it, by imputing data, we're doing it sort of one-off in different states, and it's okay, but I don't think that's where we really should be in 2022.
Yeah, great, thank you. Stacey, I'm going to give you the chance to comment on either workforce or data, but also to add the aspect of the community, because we haven't talked about the engagement with the community, and given your role, I think that's a critical question.
Yeah.
How are we seeking to engage them?
Well, I think as we talked about earlier, there's really no silver bullet, one program, one solution that can solve all this. I mean, we didn't get to this place if we didn't have some really fundamental failures in just basic ways in which we deliver care. We did a study back in 2018 and updated it in 2020, and are doing it again this year to look at what we call maternity care deserts. So a lot of people know food deserts. Well, we have about over half of all the counties in this country are considered full-on maternity care deserts, have no access to care, no obstetric care, no OBGYN, no certified nurse midwife, no birthing center, and the full half of all the counties have either no care, none of that care at all, or have maybe very limited care. So what you're talking about is we've got over half of all the counties in the country where women are having to travel enormous distances, if they can do so, to even get to a prenatal visit, right? So this aspect of what are the parts of care that wrap around a woman to help support her journey through pregnancy and through childbirth, we have a lot of gaps. So some of what we've been working on at the March Dimes is how can we do a better job of investing in digital health to close those gaps, and that was especially important during the pandemic. During the pandemic, we saw an 18% increase in maternal mortality, by the way, largely because of death among Black and brown women. And obviously, we know women in rural areas are particularly vulnerable. So telehealth and digital health is super important. And we're actually, through a venture philanthropy fund we've started, are investing in some of those solutions. But we also have some partners that are doing some other innovative things, like we have mom and baby buses that literally take care to women, these huge buses where there can be screenings on the bus. We can do all kinds of things on the bus. The bus in DC that I'm thinking about is manned by a midwife who offers care and services to women. Most of the women that go to our buses tell us that they would not be eligible to get care anywhere else but on this bus, either because of their insurance status or whatever. So it's things like that. We have other partnerships around community health workers, so where workers actually go to the home, visit with the mom, nurse, home visiting programs are also a part of that. So there are a lot of different aspects of care. Group prenatal care is another one where it's, we think about this aspect of care as being very one-on-one, but what we find is that group prenatal care, centering and other models, provides an enormous, improvement in outcomes, especially for women of color, we have found. And so there are a lot of different, in addition to doulas and midwives and all of that, I think we do have to think about the layering of care that is needed to fill in the gaps of what's not available in communities that women often need to rely on that they don't have easy access to today.
Great, thank you. I think what you're hearing is there are no one-size-fits-all solutions, and it's critical to be able to have the data to evaluate what's working and what's not, and to expand our workforce in order to be able to meet the need. What I'd like to do is open it up to the audience to see if you have questions for this panel. Okay, I will start over here on the left and move as far right as we can.
A mic is coming.
And please introduce yourself briefly when you start.
Hi, thanks so much for this panel and for taking my question. My name is Karen Landman. I'm a health reporter at Vox. I'm wondering if you could all, or whoever would like to, speak to the added threats to maternal mortality that you expect to see in the event that Roe v. Wade is overturned, as so many of us expect that to happen in the next couple of months, weeks. And what solutions you may envision in that space at this stage. Thanks.
Who'd like to start with that question?
I'm happy to or unhappy as the case may be, to answer the question. Look, it's been on our minds for the better part of the last several weeks, I guess now months. And what I would say to you as we approach our focus on maternal health, we have to realize that we have to operate within the framework of the law. And the fact that we have health plans in all 50 states with markedly different laws, to me, in many respects, doubles down on the importance of this work, right? So we're going to focus on maternal health, and we're going to do all the things that we've been talking about in terms of access and building that access, whether it's the community-based resources we've been talking about today, whether it's our implicit bias training that doesn't go away just because of changes in law. We still have to get at these root cause issues. Some of the community-based programs, the social determinants that you talked about, Stacy, right? We're still going to double down and produce the kinds of programs, or invest rather in the kind of programs that we do now in terms of delivering nutritious food and food counseling to pregnant moms, to double down in Be More for Babies, a program we have in Baltimore that has improved infant mortality by 30% over the last decade. So our degrees of freedom may be limited because we have to operate within the framework of the law, and we're going to double down in the places we can have a big input despite the laws being what they may be.
Yeah. Anyone else want to comment? No. Stacey?
Totally agree.
Okay. Okay. Thank you. I think we had a question in the back, the woman in red.
I like that, the lady in red. So when we were talking about layering the levels of providers, so many states, less than half, don't have full practice authority for so many of our nurse practitioners. That feels like it's an artificial barrier. It is an artificial barrier to making sure that we have access and good quality care. What are you guys doing to make sure that we're talking with our state legislatures to make sure that everybody's working to the top of their license, their skill, and their training?
Well, I'll just tell you a couple of things. One, thank you for putting that on our agenda. Now we have another thing to fight for, which is nice. I'll tell you that we'd love to connect with you. I mean, I think you're raising a very important issue. One of the things I mentioned about our report that's coming out is that we're expanding the focus of care to look at even federally qualified health centers, to look at family physicians and others. I think we are going to have to think about the kinds of care and who are the care deliverers that are available to women to help them wherever they are. You know, I would also say that our advocacy extends at the March Times, not just a federal advocacy. We have a huge effort there. But this year, we actually launched a whole statewide, what we call March for Change advocacy days at the state capitol that have been incredibly successful in bringing volunteers and advocates from everywhere to meet with state legislators, to meet at the state capitals to talk about some of these issues. I'll tell you, and I won't take credit for this at all, but I'm originally from Georgia. I don't live there now, but I'm originally from Georgia. And one of the issues, obviously, in the South has been, among a lot of southern states, was extending Medicaid postpartum, as in all states, but extending Medicaid postpartum 12 months. That was a big effort in Georgia. Georgia had moved it to 6 months. We were there with a bunch of advocates, literally in the hallways, just talking to state legislators and, you know, really pushing that issue. And after a lot of hard work by a lot of partners, not just March of Dimes for sure, but after that big day, within 3 weeks, the bill got changed to move it to 1 year. My point on this is to say that a lot of us think that our voices don't matter in these things. And we get lulled into thinking that what we demand and want for ourselves and what we know we want for ourselves and our daughters and our granddaughters, that we don't have a voice in that, and that is simply not true. That right now, given the state of a lot of things, this is now the most important time that we could be advocating for the things that are needed to focus state legislators on, and congressional members and everyone at every level of government, to come up with solutions. And to your point, the last thing I want to say is states really are really important. We talk a lot about what happens in Washington, that's really important, but it's where the states are doing the most work that can really move the needle, and sometimes even faster than what can happen in Washington, as you all know. So.
And I would certainly agree with that. Our administrator, Shakita Brooks-LaSure, has held a number of roundtables with the range of providers, including with midwives and doulas, and that your issue has been one that has been shared in Technicolor in some cases. And so for us, certainly at the federal level, we can send a strong signal about the importance and the criticality of these different roles. Certainly, and also then through our models, we've been looking at what are some of the waivers and flexibilities that we can try to help to address issues in terms of covering certain provider types, providing adequate funding, meaningful funding, because we also heard even in states where different providers are covered, sometimes the amounts that they're able to be reimbursed is far beneath the actual cost, the actual cost of care. So all of these different issues are very much on our radar, and I appreciate you continuing to flag that as we move forward.
One slight agree with both my colleagues, our colleagues' comments. One thing I might just sort of add as a slight additional comment is it feels like we're at an interesting point in that conversation with respect to we're 2+ years past the start of the pandemic. The burnout in healthcare is at an all-time high. And so it feels like in some respects, this is an opportune time to have that conversation, right? We need alternatives. It turns out that we can't keep doing what we've always done, and in fact, we need some new approaches. So I might just say this might be sort of a window of opportunity. So we support the advocacy work and doing it at the state level.
Goes back to the old adage of never waste a crisis.
That's right.
Yeah, absolutely.
So Lauren, I think you had a question as well.
Yes, I did. And my name is Lauren Smith. I'm with the CDC Foundation, and good morning. My name is Lauren Smith. I'm with the CDC Foundation and pediatrician, former public health officer for Massachusetts. So you started to talk about two things. I wanted to just lift up the name of Dr. Shalon Irving, who was an amazing researcher, epidemiologist at CDC, not the foundation, but at CDC, who actually died 3 weeks after she delivered her first child in 2017, even as she was a woman who was specifically focused on inequities around birth and other things. So the bitter, cruel irony of her losing her life, I think I just want to lift that up as other examples of the folks who had suffered that fate. I would love to go back to the conversation we were having before women even become pregnant, because most of the conversation, understandably, has been around different models of maternity care, but we know that women of color carry with them a burden of chronic disease that puts them at risk for bad outcomes well before they even get pregnant. Yep. So could you all speak a little bit to that? Because I think our natural tendency is to think about what we can do once we know that the women are pregnant, but the ability to address health issues before and between pregnancies, which of course means you need to control when you are pregnant.
Yes.
Can you speak to that?
It's a great question.
Just chime in quickly. So first of all, thank you for raising it about Dr. Irving, because that's an important, her life meant something, and the unfortunate irony of her losing her life as she worked on these issues, I think is a good point. So we are seeing, obviously, women getting pregnant at older ages, and that is, for a lot of Black and brown women, that's an important issue because there's this whole concept of maternal weathering that really shows that, especially for women of color, outcomes can tend to deteriorate over time with age because of the weathering, mainly due to stress, largely due to racism and discrimination that many women of color face, that then impacts their health and impacts the health of their babies. That's a real issue, especially as women choose to get pregnant later in life. And we are seeing that that is contributing, in some cases, we think, to some of the poor outcomes we're seeing in maternal health and infant health. It does speak to the fact that we have to figure out how to get care to women earlier and sooner, before pregnancy, absolutely during pregnancy, and then in the postpartum phase, as we've talked about. You know, I'll just tell you this quick story. My father was a physician. He practiced in Atlanta, downtown Atlanta, Georgia, for 50 years. When I was a young girl working in his office, pre-HIPAA, don't kill me, my job was to clean out files for, you know, patients that hadn't been there for a while, and didn't know any of these women, but invariably I'd always see that most of his patients were covered by Medicaid and Medicare. They were Black women mostly, Black people and mostly Black women. And they always had issues around diabetes and hypertension and, you know, the usual suspect of chronic conditions. But the thing that my father noted on their file mostly was that they suffer from anxiety. And I remember telling him, I was 14 years old, I was saying, you know, I didn't think anxiety was a thing, right? Because people say, oh, have some anxiety. And, you know, as a child, you don't hear that as a true medical condition. And when I talked to my dad about it, he said, no, Stacy, it's a real medical condition. But I'm just saying this to say that I also understood very keenly at a very early age the connections between stress, anxiety, and these chronic health conditions. So when we talk about, and we had a whole breakfast, Kim hosted a wonderful breakfast on youth maternal health this morning that I got a chance to go to. These issues of maternal health, women's health, mental health, and our physical health cannot be broken apart. They are all in one. So even as we get to these issues of how we help women manage their health, we have to begin to factor in that mental health has to be at the forefront of that overall health continuum in ways that we haven't traditionally done in the past. And I think your point is well taken, and I think it's still a lot of work we have to do.
Yeah. So we have oh, go ahead. Were you going to say something?
Go ahead.
Well, I was just going to say quickly, agree with everything that Stacy said. We have a national health equity strategy we launched. We started with maternal health, but again, I know we draw these sort of artificial boundaries because it turns out if you really, you know, pull it apart, and we totally agree on the social determinants, we totally agree on the stress that's added by being Black, and then you add into stress of a woman's life, right? The most physiologically complex time is when you're pregnant, and then you add the emotional vulnerability, and you need many, many different solutions to address just the basic needs. Having said that, I was pivoting to embedded in this national health equity strategies, not just maternal health, but some of the root cause issues. And next, cardiovascular is sort of our next big, not maternal, but health equity platform to say, turns out these conditions are not just specific to the issue of maternal health, it's just where we've started. So in any case, we have more work to do, but they're sort of artificial boundaries, a little bit sometimes for the focus and the commitment and the partnership and the advocacy, and yet you can't really separate them. So thanks for the question.
I want to give Dora the last word here.
I'll just very quickly, completely agree with both of my colleagues, of course. I would also say at CMS, we're increasingly focusing on primary care and thinking about integration. How do we ensure that behavioral health is integrated in primary care into integration? How are we thinking through how primary care is being aligned, integrated in with maternity care? How's maternity care? How are primary care practitioners thinking about their role and working as part of the team, taking care of moms? And so I think that's just another critical issue. We also haven't touched on integrating clinical and community-based interventions, squarely focusing on the social services sector. And I think to the extent, as we've talked about, housing and food insecurity and other stressors can have a direct impact on health. That's another area that's getting a welcome new energy and excitement in terms of what the possibilities are in that area at the federal and the state level.
Great.
But
Well, thank you. And I just want to give Kim just our last opportunity, a call to action from this very engaged group here at Aspen.
Well, first I'd say thank you, right? And we started this process by holding ourselves accountable, by saying, look, we're going to say out loud that we have a bold goal. And that bold goal is to reduce disparities by 50%, starting with maternal care in 5 years. It's not something we can do alone, though we are holding ourselves accountable. And that's why we need great partners and thought leaders and regulators and so many of you in this room to double down on these complexities and these complex issues, I should say, because this is, of course, not a one-size-fits-all. But we're thrilled to have the conversation, to share with you some of our thinking, and to advance some of the solutions. So thanks for your time today and the conversation.
Great. Well, please join me in thanking this amazing, committed group of leaders.